Good afternoon, everyone. My name is David McSwain. I am the Chief Medical Informatics Officer for UNC Health in North Carolina. And it's my pleasure this afternoon to moderate a wonderful panel on the history and future of telehealth. I have been personally engaged in telehealth since around 2009. My journey in digital health actually began with telehealth. I'm a pediatric critical care physician, and relatively early in my career in the PICU, I began developing a program for outreach to rural emergency departments to provide real-time telecritical care consultation for children that came into those emergency departments acutely ill and injured. And from that experience and from the work that I did in that space, my engagement in telehealth really grew both at our institutional level and then at the state level, moved into the national work, particularly in the pediatric space, developing pediatric telehealth guidelines nationally, and then developed a pediatric telehealth research network called SPROUT, which stands for Supporting Pediatric Research on Outcomes and Utilization of Telehealth. We conducted a national pediatric telehealth landscape survey back in 2017, and were able, through that survey, to build a broad coalition of pediatric telehealth leaders across the country, as well as collect a lot of valuable data on the programs that were being offered around the country. And fortunately, because of that foundational work that we had done, we received NIH funding in 2019 to form the SPROUT CTSA network, which stands for the CTSA is Center for Translational Science Awards, with the goal of developing research frameworks and tools that could be used to study telehealth and demonstrate value and demonstrate the impact of telehealth across a wide variety of telehealth programs, not just in pediatrics, but really beyond. And we've been thrilled to begin working with the American Heart Association as well on incorporating some of those tools developed through that program into the work that the American Heart Association is doing. Now, note, I mentioned that our grant was awarded in 2019, and around in 2020, there are some significant events that happened that influenced telehealth. Obviously, the COVID-19 pandemic caused a massive uptake of telehealth around the country, and many would say that that uptake was the key to telehealth gaining prominence and becoming more universally accepted. I think what we've learned, though, is that the most important impact of the pandemic on telehealth was in that it forced the integration of telehealth with in-person services. And that led to a focus by health systems. It led to a focus by payers. It led to a focus really across the country on how do you integrate these services with your in-person care rather than are we doing telehealth or in-person care. And I think that's an incredibly important distinction as we move forward into the future of telehealth, that we're able to understand that those are different things. Very often when you read the research, when you look at the conversations that are had around payment, the discussion is around telehealth versus in-person care. And I think that is that's an inaccurate way to approach the conversation, and it's part of the reason that we've had a stalemate around payment, continuing payment for telehealth, because those that are making those decisions, having those discussions, are looking at it as telehealth or in-person care, telehealth versus in-person care, when in fact the comparison is integrated telehealth and in-person care versus standalone in-person care, or in some cases standalone telehealth. So that's one of the things that I'm really excited as we move forward into the future, is the increasing understanding of the value of that integration. And also there's so many amazing, there's so much amazing work in the virtual care space around the country that has certainly been accelerating over the past several years. And today I'm really excited to have a wonderful group of panelists join me to discuss their work and the future of telehealth. And so I'd like to introduce our panelists up to the stage. We have Dr. Jana Goldberg, who's the Chief Medical Officer for Heartbeat Health, Dr. Carolina Scaramutti, who is a professor in the University of Miami School of Medicine. We have Rakesh Shah, who is a founder, CMO, and chair for DRS.LINQ. And we have Craig Beam, who is one of the leaders of the American Heart Association's Center for Telehealth. So with that, I'm going to transition over to the chair, and I don't know if I have it, there we go, and get a microphone for myself.
Well, as everyone's coming over to join us, I wanted to let you know that if you come and listen to this amazing panel, hear more about the future of telehealth, we're also giving you guys a Zoom light that also has our website on it that gives you some insight about the certified professionals for American Heart Association for individuals, those that are advancing their career in telehealth and telehealth stroke. So we're giving away these little Zoom lights, so come over and get one and listen to our panel over here at the Innovation Center. Thank you.
All right, thank you very much. So again, this is really a fantastic panel we have up here. We've had conversations beforehand, and the conversations have been wonderful around this topic. So I want to start out just by giving everyone an opportunity to introduce yourselves. So I gave everyone's kind of name and role, but if you can give me a brief, your history with telehealth and why you feel like telehealth is important. So we'll just go down the line. Craig?
So I'll start. My first, you were 2009, your first telehealth. Mm-hmm. Mine was the year 2000, and became intrigued with it, was doing some work with an FQHC in El Centro, California, in Brawley. They had a cohort of hemophiliacs who, when they reached adolescence, became non-compliant because they had to go all the way to San Diego for titering and treatment. And so we got a grant, set it up, worked wonderfully. A couple of papers got published as a result of it. The grant money ran out, and that was the end of it. And then had, for the next almost 20 years, had similar experiences of where we'd set them up, grant money would run out, the equipment would get shoved back into a back closet room and not get used. So it's a technology that I think we've known for a long time can help enhance access, improve care, do a lot of positive things, but until we got reimbursed for it, it was not widely adopted. So I'm excited now that at least for another year or so, hopefully a couple more years, there'll be reimbursement for it.
Hi everyone, Jana Goldberg, cardiologist and chief medical officer for Heartbeat Health. I started out my career at Penn. I was a few years on faculty, very focused in sports and exercise, and got involved in wearables, and naturally more in the innovation space. On the flip side, I was also at the VA Medical Center and saw kind of the other side, an extremely sick patients. And I remember I had one patient in particular normal clinic day in the afternoon. It was about 4:45. I think we were closing up shop. One of my patients had no-showed. And I walked down to the waiting room, and he was sitting there. I said, "Mr. Jones, are you okay? I didn't know you were coming." And he proceeded to kind of tell me about his journey to get to that clinic, taking one bus line in Philly to another bus line to another bus line to make it to my clinic for a blood pressure check. He was one particular case that stood out to me, but I had a lot of cases like that motivated me, and I was thinking about getting in the space and had crossed paths with our founder in 2019 and had since then been at Heartbeat Health as chief medical officer. And I think you'll hear more about Heartbeat Health, but you can think of us as a fully decentralized cardiology model focused on bringing in cardiology services such as diagnostics and care into settings that need them.
Hi everyone, my name is Carolina Scaramutti. I'm a postdoctoral fellow at the University of Miami. but I'm also a licensed mental health clinician by trade and have been for 10 years. I worked with community organizations, nonprofits that serve underserved communities. And so for our population, the way I got into telehealth and to telemedicine is that many of them were working parents. And so bringing their child into the office was not a thing they were able to do if the appointment was at 3 or 4 p.m. Many of them had full-time jobs, and they were coming in at 6 or 7 p.m., sometimes 8 p.m. because of the traffic. And a lot of them were no-shows as well. So these children weren't able to get treated as they should. And so telemedicine, telehealth, allowed us to see these patients in other times. So we had patients being seen at 7:30 in the morning. We have patients being seen at 7 p.m. And 8 p.m. And a lot of them are in a better mood because they didn't have to sit in 1 hour traffic. So,
Rakesh, Shah. I've been a cardiologist now for about 23 years, half of that time spent as an interventional cardiologist. But my journey into telehealth, telemedicine, really started with me doing my MBA when one of my classmates said, Rakesh, if my mom has chest pain, what do I do? I tongue-in-cheek replied, you call 911, you get her to the emergency room, she needs an EKG. But it was the follow-up question that hit me hard. He said, you know, I lost my mom at a young age, my dad at a young age, and I worry about my mom. I travel all over the world. Isn't there a better way? At that point, I realized I have healthcare security for my loved ones. Most people, 95% of the population does not. So how do we change this? And that's where I started to think about this problem, vet it out, and develop DRS.LINQ and our product called mHeart, which is to mobilize a 12-lead EKG and provide clinicians and the patient immediate engagement so that care can move on and bring awareness in terms of cardiology.
Thank you all. And I'd love to know, so from my personal experience in developing the pediatric critical care program and other telemedicine programs, often when you encounter critics or naysayers, right, they will point to, yeah, this technology sounds great, but here's a situation where clearly telemedicine would not be appropriate, or this acute situation is where telemedicine clearly would offer a lower quality of care. Now, my response to that has always been, well, we're not talking about telehealth, just telehealth. We're talking about telehealth as a component of the care that they receive, and our service was able to provide it, provide pediatric critical care expertise in a location where otherwise they would have gotten none. And so it's about that integration, and it's about changing the conversation from telehealth versus in-person care to integrated telehealth and in-person care. And I'd love to know, with your programs and your services, how do you integrate with in-person services? And so we'll start and go the other way with Rakesh.
I don't see it as a replacement for in-person care, but rather complementary. In other words, there may be times when the patient needs to come in, but let's think about all of those people who don't have access to care. Just as a simple statistic, 46% of the counties in the US do not have a cardiologist. So just take that in for a moment. How many people are suffering due to lack of access, which drives up mortality? If we can connect all of those patients in rural America with a major medical center or an institution, you can drive a reduction in mortality just from cardiovascular diseases. Those patients who ignore chest discomfort, but now they're connected, they would have an opportunity to seek out medical care in a much more timely fashion than what currently occurs.
As for mental health, a lot of our clients do not have acute crisis situations, and that would be one of the exceptions of when telemedicine would not be helpful for a client. They would need to go in person and have a more complex treatment for care. However, most of our children want just therapy for anxiety. They want to know how they can focus better, how they can provide better communication within their family. So I do a lot of family functioning, and these parents are trying to communicate with their teenage children. And so they don't need to come in person. to do that. We can have them over a Zoom call, and we can have a good therapy session. Now, as far as research, what I do at the University of Miami, we are also implementing VR. So our lab with student athletes, we're having a VR lab that's being implemented in their department where they exercise. And so where they exercise, they're already able to use this VR so that they can have stress management techniques, they can focus better, things that they wouldn't do coming in person. The new generation doesn't like doing in person. They like to text, they like to send emails, they want to do everything but be in person. So this would be an integrated care where they will learn these techniques using VR, and then the door is always open for their sports psychologist, and they can come in, and then that opens the door for a conversation. Hey doc, I've been using this VR, but I don't know if I'm doing it right. Can you help me? And then they'll come in person and be able to do that. But it opens the door when, in the first place, they wouldn't even come.
So I'd say from the heartbeat standpoint, so we've built really a fully integrated cardiology model. And by that, I'll dig into a little bit. So our largest channels of growth have been within the value-based care setting. So bringing in cardiology to large ACOs, primary care organizations that want to start to take on more specialty care, start to get their arms around it, as well as the home care setting. And so a few kind of key themes that I think illustrate the hybridization of what we've done with those channels is, number one, shifting testing upstream. So if you imagine, traditionally, if a person has a cardiology complaint or they're high risk and you want to get a test on that patient, you are then going to refer that patient to a cardiologist, where then they have to make the appointment, get to the appointment, be seen by the cardiologist, then get a test ordered, then maybe or maybe not make it to their test, then have a follow-up visit. So one of the things we've done is start shifting testing into primary care settings, such as echocardiography. So we have a large sonographer workforce that is in primary care clinics deploying echocardiograms. We do a lot of rhythm monitoring, so I've deployed those patches so that they're in our primary care clinics. And so shifting those upstream. I say secondly is just this collaborative two-way communication that really needs to happen between cardiology and primary care. I mean, I came from the system setting where I have to admit, I did not always communicate with our primary care clinicians, and they really, really are central to care. And often I don't think we've quite necessarily appreciated that. So we are inherently in their system. We are getting on the phone with them. We are working on care plans. We had a patient just actually a couple weeks ago, 94-year-old woman who had not engaged in the system. She was hospitalized last year with chest pain, heart failure, declined intervention, didn't want anything done, and her home care, her primary care and at-home presence was trying to manage her on their own, and they were failing. She's wheezing more, she's holding on to fluid, and so we got back involved in her care, really to focus on aggressive medical management, but really palliative in nature, to have a conversation with her home care team to say she doesn't want any procedures, she doesn't want to go into the hospital, and we really need to focus on medically managing her at home, actually in her assisted living facility, because her primary goal was to be able to socialize, feel well enough to walk down the hallway and interact with her peers. And that, to me, is true collaboration. When you look at take that, that heart failure as an example, only 5% of patients with severe heart failure actually get palliative medical management. And we just don't have the infrastructure to do that. So as part of kind of the channels we've built out, that's been also a natural part of it, is to support medical management for patients who really need it. And I think those cases like that just resonate.
So I think that's an important component. We think of telemedicine and telehealth as retail. The physician talking to the patient. And you certainly pioneered this, and I go back to, I'll give another example, Bakersfield Memorial Hospital. Bakersfield's kind of in the middle of nowhere in California, so it's 3 hours to the next children's hospital in Fresno. It's probably 4 hours with traffic to UCLA or Children's of LA, and they wanted to establish a pediatric program. Well, the only way we could was by having Children's of LA interventionalists available for telemedicine. We were able to recruit hospitalists, but we couldn't get intensivist. I said intervention, intensivist.
We're hard to come by.
Yeah, I know, because you're hard to come by, and who wants to live in Bakersfield when you can live at west side of Los Angeles? But so, I think there's layers to this as well, not just the retail component, but as you said, coordinating between the care plans, between the internal medicine or family practitioners and the specialists. And so I think we need to keep that in mind. Sutter pioneered it with EICU for their rural hospitals as well, and this is probably 20 years old now too. Been around too long. 20 years old now, of where they had intensivists available so that they could keep the people in the community. So in Bakersfield with a pediatric program, every time they had a PICU, that was a helicopter flight. And that's $50,000 a trip. And then the family generally couldn't go with them, so they're driving there 4 hours later. So I mean, it really does have some very nice tangible, like you said, for the CHF patient, being able to keep them in a setting that they're comfortable in, or in this case, keeping the pediatric cases in the community. Yeah. And I know that you spent a lot of time on that, so.
Oh, we absolutely did, and one of the big outcomes from our pediatric critical care program was those avoided transports. And even if patients were transported, we would avoid the PICU stay because we were able to assess them more accurately and intervene earlier and often send them to the floor instead of the ICU. So we saved millions of dollars for payers. And, other programs, we've studied a pediatric wraparound program for medically complex children that we demonstrated through some of our Sprout work using our economic evaluation tool that they saved millions of dollars for Missouri Medicaid. And the Medicaid programs took note of that, obviously, and have actually really jumped on that program. We're seeing that expand across the country. But one of the key points as we talk about this integration, and Craig, this is for you, when you have providers who are they're in-person care providers, but they want to integrate telehealth into their practice. Now, during the pandemic, obviously, everybody had to do it lightning fast and kind of just off the cuff. But what's the role that education plays in helping to facilitate that integration? And tell us a little bit about the work that the AHA is doing towards that education.
So I think that's a great question. So, and again, this is experiential. So pre-pandemic, it was very difficult to get a lot of physicians, sort of your age and my age, to participate in telemedicine because it required a certain level of technology competency. And I think a part of what happened during the pandemic is here's an iPad, figure out how to use Zoom, and you expect your patients to figure out how to, but we're Microsoft Teams, so we can't do that. So I think that there's some of just the pragmatics around it. And again, pre-pandemic, in some cases, we built studios so the physicians could go into the studios and do their consults, and they had tech support. That was Sutter's model of having tech support in the studios to do it. I don't think that's a sustainable model, but I do think we need to be able to train people on just the pragmatics. There's legal aspects, there's reimbursement aspects. So our certification programs touch on all of those, and now we're adding in layers of specialty. So mental health is one of the more established telemedicine programs. So certification around behavioral health, we're going to add stroke, we're at cardiology, obviously, but very different specialties so that people are trained, and also not just physicians, but the support staff, the advanced practitioners also get some training in how to do it. And, it's also multimodal, so we all think of it as Zoom or something, but a lot of it's over the phone now. Yeah. And because people are comfortable doing it over the phone, and there doesn't need to be a lot of technology, which gets back to an access question, which I'll look to these guys on, is, the other thing that we found is there's generational obstacles to it. My mom's 91. She's 91. She would not no more open a laptop or a computer to do something. She'll talk to somebody on the phone. And then there's cost. Inland Empire Health Plan, we did one, and what we found out was within the first week they'd used up all their minutes. And so there was no availability after that. So maybe you guys can, I'm taking over Dave's role here a little bit, but talk about access and how we really use this as a tool to build greater access, and not just for people that can afford it and know how to use the technologies.
I'll jump on that.
Great question.
Thank you.
So you've raised a really important issue, our elderly. If you look at the statistics, it's the elderly that often don't have a cell phone or are very much technologically challenged. those are the types of people that we can help with telemedicine as well. They also have a hard time coming into the office. I remember a distinct phone call a couple of months ago from one of my patients, and he was trying to bring his wife in, and he finally canceled the office visit and begged, can we do a televisit? I've said, absolutely, you don't have to beg for this. But we just didn't get enough information to help manage her. Right? So this is where new emerging technologies, or taking old technologies and repackaging them, making them easy enough for them to be applied and utilized by family members that then don't have to necessarily worry about taking an entire day off or getting grandma into a wheelchair, into a car, into the office, but, you know, and in and out, and it's so challenging. Now all of a sudden, people can maintain their everyday lives while also being able to provide care for their loved ones. And I think that's a big part of telehealth and would be a great use to help improve the quality of care delivery and improve outcomes in those elderly patients.
And to add on to what he said, we're doing at the University of Miami a decentralized trial where we are using a multimodal approach for patients with cardiometabolic diseases. But a lot of our patients are older, and so we're doing push text for those who only have text messaging systems, but we're also doing an interface where part of it, it's a 4-arm trial, so they're randomized to each arm. The first one is standard care. The second one is giving digital literacy and health knowledge. So what is an EHR, electronic health records? What's your privacy rights? How do you access these applications? And just basic knowledge on how to use these tools. And so being able to be empowered to use these tools, they're more likely to be able to get a grasp on their disease and as well as their treatment plan. And then we go all the way up to the 4th arm where we have a social care navigation application that's AI accessible. So you put in through a survey, we use Prepare, and using Prepare, we're able to assess what it is that they need, and the AI will prepare a personalized care plan where they can use their community resources to be able to access the things that they need to make their plan better, their treatment plan. And so we start all the way from push text all the way up to an integrated care model.
That's fantastic. I'll add, I mean, from our end, I think it's been about optionality, honestly. I think in the past, like, patients only had the option to come in person. Now we have multiple options. We have televisits. We've learned that you can't have a Medicare-age population downloading an app and remembering a login. I can't even remember my login. So we've succeeded with just a text message. They just literally clicked the link, and we found that worked well. Audio-only visits when needed, right? And we found that our older patients tend to lean into those visits, especially if they don't have someone else to support. So supporting care pathways that utilize that. And then also, I think as Carolina, I think what you're examining right now with your own research, which is other ways to engage a patient that works for them, whether it be text messaging, right? So we're going to see our younger generation is going to engage more with text message, and so you're going to want to utilize technology like that. And so I'm happy we've evolved from telemedicine to virtual care to, I think people are starting to understand that it's much bigger about that. It's about creating that optionality and building out care pathways that fit the patient and ultimately get the job done, get that patient managed.
So I've had a bit of an epiphany as we sit up here, is I think we need a certification for caregivers, because with the elderly, so that we can train them what the tools are. And so if Chrissy's in the room, that's my on the parking lot list of next certification for us to do. But and the work that you're doing, I think, is very important about randomly controlled trials around this, because what we hear from the payers is, yeah, it sounds good, but you got to prove to me that it. And they even don't say it has to improve care; it just has to be equal to the care that they're otherwise given. So a lot of the research has been observational, and we really need to improve the rigor, which David has been a key proponent of and participant in through the search group. So,
yeah, and honestly, one of the reasons that I'm very excited about the work that the AHA is doing in this space and regarding with education and the certification approach, folks may say, well, it's the American Heart Association, and so of course, well, so sure, you know, telehealth services focused on the heart, but like, why broadly? Why is the AHA the organization to do this more broadly for telehealth? And the answer there is the AHA is an incredibly research-focused organization. They're an evidence-based, evidence-driven organization, and the AHA has the kind of foundational expertise in incorporating evidence and research into education and best practice that I think really can set the standard for how we approach this. And we've talked a little bit about some of the research work that you've done. I would love to hear from the standpoint of how do you evaluate your programs, whether that's formal research or whether that is quality improvement sort of efforts. How do you evaluate your programs to demonstrate the impact and the value that they have? We'll start with you.
Okay, sure. So it's evolved. So in 2021, when we ran our trial, we were specifically looking at feasibility, safety, and whether or not we kept patients out of the hospital. So essentially, with that trial, we compared usual care, which was patients who were discharged from the hospital and followed up with their cardiologist and primary care per routine, versus usual care plus our program, which was a combination of televisits, remote monitoring, care coordination, and we saw significant reductions in all-cause and cardiac readmission. So the first, I think, and this is sort of in line with where the evolution of things have gone, is we wanted to prove it was safe, we kept patients out of the hospital. Now we're looking at it differently. We want to know what are the long-term implications and impacts of what we're doing. So specific questions that we are asking now are, what does introduction of early testing and early medical management do to long-term outcomes? So a specific program, for instance, is our Stage B heart failure program. So we do a lot around identifying patients who are high risk, diagnosing them with Stage B heart failure, and then building out care pathways to manage those patients. A lot of them can be effectively managed by their primary care with a little bit of cardiology support. They don't need to see all of us. And facilitating higher needs pathways for those sicker patients. And so the questions we are asking now are, okay, well, are we actually preventing progression to stage C heart failure? Are we actually going to save lives down the line? And so we're a few years into that. I think we're going to start to see that data unfold. We're optimistic based on the trials that have been done. But I think it's an exciting time for us.
For us, we do evaluation pre and post. So to begin, we start with focus groups. We try to ask the patient, the person, what it is that their barriers are. What are their facilitators? What will get them to use an application? How will we make it easier for them to access their electronic health records or access their treatment plan and their medication management? And then we build from there. So our interface model was based on what we got on our focus groups. So now we're in the phase where we are implementing that clinical trial. But the way that we're going to test if this was an improvement is their health outcomes. Did they do their medication management? Did they log in their physical activity? Did their blood pressure go down? Are they eating better? Because those are part of the components on the multimodal approach that we're using with these applications. But we're also looking, how many times did they click in? Did they log in their diary? Did they call the professional that they're working with? And did they go to their appointments? Because all of this is accessible in their application. And so we're able to see it on our side, and then hopefully we'll have positive outcomes.
So our journey is a little bit different. MHeart's in its very early stages, infancy if you would. But we already have 3 major health systems that are interested in piloting MHeart simply because of the value proposition it provides, reducing the overall cost of care while improving cardiovascular outcomes, morbidity and mortality, and early detection of cardiac events. And so these institutions are struggling with the same issue, again, in terms of health care equity, access to care, and especially for a number of systems that have patients traveling 30, 40 miles, they want to be able to reduce their own costs for transporting these patients. So they're quite interested in teaming up with us to demonstrate all of this. So the socioeconomic and the healthcare data will be forthcoming in the next few years.
And then I think for AHA with the certification, so this is part of a robust suite of certifications. Same thing, we're early stage, launched in the last year or so, but like Get With The Guidelines is 20 years old, and there's been hundreds of research papers written using that. So as this evolves, we also want to prove that the certification process is in fact worthwhile, improves outcomes, enhances cares. We're not there yet, but we're starting, and that gets back to sort of the core competencies of the organization, is being able to do that.
Yeah.
I was just, you've been in it for so long, both of you have been in it for so long, but I think when I kind of got into this world in 2019, when COVID hit, it was like the wild west. It's $6.5 billion put into about like 135 companies. There's also
Forget about HIPAA or any...
just wild west, and it is a new era. We have to create some rigor and ensure what we are doing is actually working. And I think we're starting to see that. I think it's really nice to see what the AHA has done also to support that.
Well, and I think as we're moving out of that Wild West era and moving out of the pandemic flexibilities, what we've seen
David's
with
one of the ones that got the money, by the way, in that one. So, sorry, David.
What we've said, do what I can. What we've seen is kind of a kick the can down the road approach in terms of extending the payment flexibilities around telehealth. And the justification for that from the Congressional Budget Office, from policymakers, is usually we need more evidence, right? And the point that I continue to try to make, and hopefully one day will really stick, is no, we don't. Now, we actually have a very robust evidence base around the value and impact and cost reduction capabilities for a huge variety of telehealth programs. But what the Congressional Budget Office is looking for is more about thinking of telehealth as its one thing, right? And looking at claims data and getting those results mixed in with all manner of different programs, some of which improve utilization and reduce costs, others of which can increase costs or increase utilization. And I think the key to move us beyond this stalemate is to have that discussion around, look at the research on these integrated programs, looking at them more specifically in terms of, yes, this cardiac program, this virtual cardiac rehab, pediatric critical care, telemental health, specific programs that are offered in an integrated way have a ton of evidence to support the value and the cost reduction and decreased utilization, unnecessary utilization, more efficient utilization. And if we can shift that conversation in the policy and regulatory space to that level of understanding, I think we can actually make some progress there. One thing I'd like to dive in on a little bit more is that each of you have touched in some way on the equity aspect. And I think one of the things that we really saw during the pandemic especially was that telemedicine, which was often billed as a great tool to address inequities, due to the rapid expansion, we actually saw some exacerbation of inequities. And so there has been a lot more attention paid to how do we address equitable care delivery via telehealth? How do we address those issues that we saw, like around availability of multilingual support, for example? And I'd love to know, how are you addressing, within the work that you're doing, the equity aspects of that service delivery? So we'll start with you, Rakesh.
That's a loaded question. But no, it's a really important one, right? And I think talking about the language piece is really important. What we're working on initially, will it be available for patients speaking Hindi or Gujarati or some other language than English? No, and it shouldn't be unless they're proficient in English. It's not to say that that's not a future state, something that we can't develop, but I think you speak to really important points. We need to make sure that the patients are capable of utilizing the technology. We need to make sure that they're properly educated. You brought up the issue of loved ones being certified to manage the technology, or some sort of proof that they're able to manage the technology and provide the care delivery. So I think as we go on, we're all going to be learning about this together and developing this. But probably the biggest thing is advocacy that the AHA can provide.
As for us, I think is being able to look at it as tequity in a way, and that's something Dr. Satius, my mentor, coined. And it's seeing that the patients that we are able to see now are patients that could not have come into the office because they are 40 miles away, 50 miles away. So we're bridging that gap on where we can access a community that may not have come in the first place to get telemental health or to get their kids seen because they don't have the time or they're not able to drive to us. So we're able to provide that on a phone or on a laptop, and that's the beauty of it. You don't need to have a laptop. You can just have a phone, and you're able to access Zoom on a phone.
And our time zoomed by, so we're at, but I want to give you, I want to, it's unbelievable how quickly it was gone, but yes, let's give you a.
I mean, it's about the data. Right. Initially, are we providing access across people? And then secondly, are we actually impacting outcomes across race, across ethnicity? So for us, it's been getting the data. I mean, it starts with that, right? Okay.
And that is a phenomenal thing to end on, honestly. I love that. I think, well, and we are out of time. I've got a flashing red light here.
Pat's standing in the wings.
Yeah, but I'd like to thank our panelists again. Please give us a round of applause. Thank you very much for your time. And I'm happy to invite our next panel up on stage.